Christina. That was amazing. Congenital imaging is my favorite migraine trigger. So that was amazing. But yeah, I read congenital on Wednesdays. We're going to change gears a little bit and talk about cardiac tumors here. I do want to make it interactive when we do the cases. I have a couple of cases for you, but let's quickly go through some slides here. All right, the most important thing when we're talking about, cardiac tumors, location, 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 right? It is the most powerful diagnostic clue to this. And as we can see in this image, myxomas are most likely going to arise from the left atrial side or the interatrial septum. Fibroelastomas, as a lot of cardiologists here know, more likely to arise from valves. Thrombi or pseudo, which I'm going to refer to as pseudo tumors, are going to be found in the left atrial appendage or LV cavity. And then in contrast, malignant tumors are more likely going to involve the right side of the heart, the pericardium, or the pulmonary arteries. So very important. Always think about the location and also look into your patient, right? Look at their age group. What sort of history do they have? Do they have a history of a primary malignancy somewhere else? Do they have indwelling catheters that could be hiding a pseudotumor like LV thrombus? So very important location and then the age group of your patient. I'm going to talk a little bit about our multimodality imaging toolkit because the reality when it comes to cardiac tumors is that we are going to have to use other modalities, right? So echo, highly available, it's repeatable, low cost, and more likely to be the one that finds an incidental mass, right? And we all know this, we're never going to beat the spatial resolution of TE, right? So TE, always a great tool that we have. Our cardiac MRI is going to be sort of that non-invasive gold standard. Whether, it's costly, it's very time consuming, not all centers have it. Yes, there are a lot of limitations, but the reality is that CMR is going to provide very high spatial resolution, but more importantly, tissue characterization, right? And then we have CT, of course, widely accessible, our spatial resolution better than with MRI. And it's crucial for detecting other characteristics of your mass, ruling out coronary disease. If we can save the patient from having to have a preoperative left heart cath, I think we're doing a huge service to the patient. And then obviously evaluating extracardiac invasion and helping with planning the surgery on patients. And then lastly, our third level sort of tiebreaker is going to be your PET, right? It highlights that metabolic rate and it helps stage malignancy or help clarify inconclusive scans. And here, I put this slide here only to say the key concept is that these modalities complement each other rather than compete with each other, and they all have a role, and you're more likely than not going to be using more than one modality to delineate tumors. My approach is sort of 4-stage. First, we're either going to identify the mass, like I said, if it's a very small mass, like if I'm thinking fibroelastoma or something like that, I'm definitely going to get a TEE. Obviously, second, I will try to get a CMR, but again, a lot of times people have claustrophobia or there's going to be a lot of pacemaker artifact, and I'm not going to be able with all the lead artifact to really sort of characterize the mass appropriately. Then I'm going to go into my CT and my FDG PET.